Okay, it's a great honor to be with you today under supervision of our eminent professor and educator, Dr. Mervat Abou Maati. Our agenda is to understand the pathophysiology of dysynchrony and why left bundle branch area basing and what are the indications of left bundle branch area basing according to available data and evidence. This is a magnetic resonance imaging of the myocardium of a canine. So we can notice that the distribution of myofibers in the heart is mainly longitudinal in the epicardium and the endocardium. And while the myocardial fibers are oriented circumferentially. And these fibers have to be activated through the His-Purkinje fibers in a synchronous manner, so that the activation of the endocardium and the apex occurs first, then the epicardium and the base at the last, with minimal regional disparities in the electrical activation. So when the His-Purkinje system is diseased, as in left bundle branch block, or when we are pacing from from the right ventricle, there is a disparity in the activation of the heart, and there's early and late activated regions that contract out of phase with each other, generating dysynchrony. Here we can notice that some parts are activated early, some parts are activated late, and there is a waste of energy between these two curves. First septal activation occurs first in conventional RV basing and in left bundle branch block, while the lateral wall of the left ventricle remain silent. So forces from the septal contraction are not enough to raise the LV pressure, but they are laser converted to pre-stretch of the lateral wall. This leads to a slow rising of the delta B to delta T and increasing the lateral wall stress. So in early systole, in the isovolumetric contraction phase, there is lowering of the delta B delta T. Delta B delta T means the difference in pressure versus the time, and when it's getting slower, this means worse contraction. Then later on, when the free wall of the left ventricle contract, it generates a systolic forces, but this is very late, and it's partly dissipated by the restretching of the already relaxing septum, and there is a delayed activation of the papillary muscle, leading to development of mitral regurg that reduces the cardiac output and precipitates heart failure. So in the late systole, one territory relaxes and the other contracts. So this creates what we call it the intracavitary energy sink, meaning that the energy generated by one wall is wasted by the stretching of the contralateral wall. And here we can understand the mechanics of the synchrony. So some parts are activated in early systole and some parts are activated in late systole. So in early systole, there's a positive strain over the lateral wall, and in the late systole, there is a positive strain in the septum. And this leads to shifting of the pressure volume loop to the right, meaning that the end systolic pressure volume relationship is shifted to the right wall, and we notice that there is no fall in the end diastolic volume. So the loop area and the loop widths are reduced. The loop widths corresponds to the stroke volume. So with the synchrony, there is a significant drop in the stroke volume, and also there is a decline in the stroke work. This is also leads to increase in the wall stress in the lateral wall and declination in the delta B to delta T and the relaxation takes a longer time. Not only this, on the molecular level, there is downregulation of the sarcoplasmic reticulum, calcium ATPase, and phospholamblin. This is responsible for generation of contraction, and the extracellular response kinase, this is a protein kinase that's associated with the stimulation of wall stress pathways, is highly activated and overrepresented in the lateral wall. Also, the connexin 43, which is a gap junction protein, is markedly downregulated. So there's a decrease in the contractility, increase in the wall stress, and decrease in the gap junction and slowed conduction. And astonishingly, these molecular changes are not related to heart failure. They are only present in those with a failing heart and dysynchrony. If there is no dysynchrony and the QRS complex is narrow, these molecular findings are not present. Also, dysynchrony is arrhythmogenic. It's associated with remodeling of the delayed rectified potassium currents and calcium currents. This generates a prolonged QT, a transmural heterogeneity of repolarization, and variable areas of conduction blocks that may lead to arrhythmia in desynchronous heart failure. So Dysynchrony is a great problem, and it should be avoided. And it can be avoided by what we call it cardiac physiological pacing. Cardiac physiological pacing is a term that refers to CRT and conduction system pacing. Currently, there is a great evidence that left bundle branch area pacing is much more better than right ventricular pacing. In this meta-analysis that included 14 studies, 10 observational studies, and 4 randomized controlled trials, including 3,062 patients with AV block, the QRS complex was significantly shorter, but this is not all the deal. There's a significant increase in the left ventricle ejection fraction, significant reduction in the LV end diastolic diameter. There is a lower risk of heart failure hospitalization. All of this, and there was no significant difference in the implant success rates, the procedure-related complication, nor the pacing impedance, nor the pacing threshold. So it's safe and effective, and it led to excellent results by avoiding dysynchrony. This is another study that compared left bundle branch area pacing and the right ventricular pacing, and they studied the effects on dysynchrony by imaging. They had the echo and they had MRI for patients undergoing conventional pacing and those undergoing left bundle branch area pacing. Left bundle branch area pacing, this did not just improve the QRS complex weights, it resulted in a better synchronization and more physiological contraction. Also, there was a significant decrease in the risk of the atrial high rate episodes, so it can reduce atrial fibrillation. This is a multi-center study of the left bundle branch area pacing, and it proves that left bundle area pacing is an effective alternative to CRT. The evidence on CRT in heart failure is broad and well established. The evidence on conduction system pacing in heart failure is still growing, but the initial data are promising, but still CRT is the first option. Left bundle branch area pacing actually could achieve an interesting outcome. So pacing threshold was 0.6 plus or minus 0.3 volt at 0.5. This is excellent, as this can means a better longevity for the devices. The R wave amplitude was 10.6. There was a significant QRS narrowing, and ejection fraction improved from 33% to 44% plus or minus 11%. This is actually very promising with clinical and echocardiographic responses observed in 73% of patients. And actually, this was translated in the guidelines. Before we start, we have to review the available basing methods currently. We have RV basing, either apical or septal, or wherever you implant your lead, and the biventricular pacing with CRT, the His bundle pacing, and the left bundle branch area pacing. And when you compare all of these four methods, the RV pacing is easy, but it's associated with impaired LV synchrony and impaired LV ejection fraction. Cardiac physiological pacing by all these methods actually preserve and restores the LV synchrony and hence can improve LV ejection fraction. But it may be more complex than a conventional RV pacing. But notice this, with CRT you get a high threshold usually, as you're pacing epicardially from the coronary sinus lead and you're pacing from the RV. His bundle pacing usually have a higher pacing threshold, but the left bundle area pacing actually give you a lower threshold, longer battery longevity, and it's associated with relatively low lead complication. When you are planning to AV node ablation in patients with AF, left bundle branch area pacing is a better option than his bundle pacing. It gives you more stability and it makes the procedure easier, and there is a lower risk of rising capture threshold when compared to his bundle pacing. And the backup lead is not needed in left bundle branch area pacing, which may be considered in patient undergoing his bundle pacing, especially if the patient has substantial RV pacing. So now we move to the indications, and we're going to review two guidelines, the 2023 HRS guidelines on cardiac physiological pacing. And this algorithm defines indications of pacing and how to pace in different scenarios in patients with bradycardia. Actually, you have two factors that guide your selection. First, what is the ejection fraction? And second, is there a substantial RV pacing, which is defined by the guidelines by over 20 to 40% pacing time. So when you get a patient with an indication of pacemaker implantation, you should ask yourself, is it at the time of cardiac surgery? If it's at the cardiac surgery and there is anticipated future need of CRT, you should implant an LV lead. But if there is a substantial ventricular pacing, it's a class 2B to implant LV epicardial lead. So this emphasizes on the importance of evaluation of the expected substantial RV pacing. If not, if there is no surgery, you should ask yourself, is there an anticipated substantial RV pacing? And the answer is yes, you should go for the ejection fraction. If it's more than 50%, a CRT or His bundle pacing or left bundle branch area pacing may be considered. This is new. And this emphasizes on the importance of this thinking. If the ejection fraction is 36 to 50%, it's no longer a conventional RV lead. It's rather a CRT with a class 2A or a left bundle area pacing or His bundle pacing with a class 2A now. So it should be done. And when you are implanting a His bundle pacing, you may consider placement of additional backup leads. And this is a good point for left bundle branch area pacing. What if there is no anticipated substantial RV pacing? You ask yourself, if the ejection fraction more than 35% and the answer is yes, the best option is to implant the conventional RV lead and apply the algorithms for reduction of RV pacing, such as managed ventricular pacing or tertiary AV interval. If the ejection fraction is more than 50% left bundle branch area basing or his bundle basing is a class 2B and CRT is a class 3, if the ejection fraction is from 36 to 50%, you ask yourself, is there a left bundle branch block? If there is a left bundle branch block, CRT is a class 2B or his bundle basing or left bundle branch area basing. Why left bundle branch block is important? Because it causes dysynchrony. In the literature, there's a term called dysynchrony-induced heart failure. And they actually find that left bundle branch block itself can induce heart failure that may be reversible with synchronous basing, either by CRT or conduction system basing. Then we go to the next category of patient, the heart failure patient. And we're not going to review all the indications of CRT because it's out of the scope of today's presentation, but you can see that they give a class 2B recommendation for a patient with a QRS complex larger than 150 milliseconds and near plus 2 to 4 symptoms with either their left bundle branch block or non-left bundle branch block to implant his bundle basing or left bundle branch area basing if CRT is not available or there is difficulty in its implantation. So this is new for conduction system basing. And you notice that the indication of conduction system basing in heart failure is still lower than CRT according to the available data. However, in basing-induced cardiomyopathy, it's still a class 1 to implant a CRT, but it's a class 2A if you cannot implant a CRT to revise the old lead and implant a conduction system basing device, either left bundle branch area basing or his bundle basing. So it's a class 2A now. What about the patient undergoing EV node ablation for atrial fibrillation? It's now a class 2B to implant his bundle lead with or without backup lead or implant a left bundle branch area basing lead, and it's a class 2B. This is also new. And in general, when you are implanting a pacemaker and there's expected substantial RV basing, his bundle basing or left bundle branch area basing may be considered to reduce the risk of atrial fibrillation. This is emphasized on the fact that the synchrony is arrhythmogenic, not just for the ventricle, it's also arrhythmogenic for the atrium. Now we go to the ESC consensus statement on the indications of conduction system basing, and it's fresh. It came in 2025 this year, and it's actually simple and nice. You have 3 scenarios, which are the AV block, heart failure, and those with atrial fibrillation and uncontrolled heart rate. If you are having a patient with AV block and there is anticipated ventricular basing less than 20%, you should consider bracing an RV basing conventional, but add managed ventricular basing and reduce the substantial RV basing. However, you may consider implanting a conduction system basing, and when the block is infraheating, a left bundle branch area basing is preferred over his bundle basing. If the ejection fraction is less than 40% and there's anticipated V basing more than 20%, you should go for CRT. However, conduction system basing may be an alternative option, but notice that RV basing is contraindicated. But what happens if you get a wide or non-physiological based QRS with BiV basing or conduction system basing? This is new. The hot or locked CRT may be considered. This is where you implant a left bundle branch area basing lead and implant a coronary sinus lead so that you can guarantee synchronization. If the ejection fraction is 40 to 50%, you may consider conduction system basing, biventricular basing, or RV basing. And you should prepare a backup conduction system basing lead if the implantation of the coronary sinus lead failed. If the ejection fraction is more than 50%, you still may consider implanting a conduction system basing lead. So almost all patients, according to the new guidelines, can benefit from conduction system basing. And this is why it's important, and everyone participating in device implantation should learn it. Those with a CRT indication are divided into 4 categories. Those with the left bundle branch block, and these are the most important categories. If the ejection fraction is less than 35%, BIV basing is the best option. But if there is difficulties with it, you may consider implanting a conduction system basing. If this is a non-left bundle branch block, you go for the ejection fraction. If the ejection fraction is from 36 to 50%, BIV basing or conduction system basing is still area of uncertainty. So we don't have a lot of evidence, but it may be considered according to the HRS guidelines. If the ejection fraction is less than 35% and non-left bundle branch block, BIV basing may be considered. Conduction system basing is the area of uncertainty. This is unlike what most of people think. If you have a diseased left bundle branch block, and this is worse, and if it's a right bundle branch block, it's better. No, actually, those with a left bundle benefit more from conduction system basing than those with a non-left bundle. So if you have a left bundle branch block, this is a good point for conduction system basing. For those with a basing-induced cardiomyopathy, BIV basing is still the best option, but conduction system basing may be considered. And if the patient is not responder to BIV CRT, you may consider conduction system basing. Hot and lost CRT is still an option. And always remember, if you fail in implanting a coronary sinus lead, this is not the end of the story. You should remember that here conduction system basing should be considered. What about those undergoing AV node ablation? It's all about the ejection fraction. If the ejection fraction is more than 50%, conduction system basing may be considered, and left bundle branch area basing is the preferred option. Then his bundle basing with a backup lead. RV basing is still possible. If the ejection fraction is 41 to 50%, don't think of RV basing. Just go for conduction system basing or BIV basing. Notice here the evidence is almost equal. And when you think about it, you can just implant a single lead and it's the end of a story, rather than implanting 2 leads and making the procedure longer and more complex. If the ejection fraction is less than 40%, BIV basing is still the best option. So 40% BIV basing, more than 40%, always think of a conduction system basing. And also, there's an emphasis on the possibility of hot and lost CRT. The problem with hot and lost CRT is that the evidence on it currently is very scarce. So in the future, it's expected that most patients will have a conduction system basing or hot and lost CRT, not conventional CRT. And always remember, you should prepare your backup left bundle area basing lead or his bundle basing lead for conduction system basing. This is the final slide. Always remember that his bundle basing, although it was the first solution to achieve physiological basing, still it resulted in high lead capture threshold, high incidence is dislodgement, loss of capture, oversensing of the atrial and his potential. Revision occurred in about 7% of patients with acutely successful implants. This is a high rate of revision with increased risk of infection. Is it challenging in patient having a bundle basing, especially if you are going to implant a CRTD with it? It's actually would be very challenging, and really need a backup lead. Thank you.
Thank you very much, Dr. Rossasy, for this excellent explanation of how to choose the conductive system pacing